Two. So I'd like to thank for everyone's time joining the session today. We have the pleasure to get Dr. Eddy Fan Eddy Fan to present to all of us today on the topic of Expand ECLS. I'm sure everyone knows Dr. Fan, so I don't need to give a further introduction of him. But Eddy, can you please present, and so we can ask you questions towards the end of the session. Thank you.
Sounds good. Yeah, so thanks, Kathy. Thanks for the invitation to speak on two domains of the practical platform. So I'm presenting on behalf of our team on the Expand ECLS domain, the rationale and design. So here are my disclosures. I won't be speaking about any specific devices today. Okay, it's interesting to think about, when we think about the design of these domains and our trials and thinking about what the future of ECLS might be in the AHRF population that I'm going to be talking about today. It's often good when we think about the future to start by thinking about the past. And the first thing to think is to highlight is that as much as there's been an explosion in the use of extracorporeal support over the last almost 2 decades now, particularly fueled in adults at least with respiratory failure from the, if you will, first pandemic, which is the 2009 H1N1 pandemic, followed by then COVID. Of course, it's all still fresh in our minds, has really led to this exponential rise in the use of extracorporeal support for respiratory failure. But this is actually a pretty old technology. So back in the 60s and 70s, the advent of extracorporeal support really happened in parallel with the development of cardiopulmonary bypass by pioneers like John Gibbon in Philadelphia and others. And you can see here this very nice early description of the use of extracorporeal support in a large animal model. This looks like to me like a sheep of some sort, but this is work by Ted Koloboff, who's again a pioneer in the advent of extracorporeal support that was working in Bethesda at NIH, showing this setup in the 70s of how you might support here an animal, but of course the idea of patient, by using extracorporeal support. And the title of this article was An Alternative to Breathing. So we're still in 2025 thinking, 50 years later, thinking about how we might use extracorporeal support as an alternative to breathing. And again, this is an idea that was really had its genesis even with the very beginnings of the field of extracorporeal support. And again, very prescient by these giants in our field. Ted Koloboff, here you see Luciano Gattinoni, of course, who unfortunately passed away earlier this year. Really people who helped to advance the field of extracorporeal support. And even here you could read in their conclusions, they didn't know at the time whether you even needed to ventilate patients if they were supported with extracorporeal support. And they really felt that this technology could really affect the long-term management of patients, especially in difficult situations, perhaps with apnea. Okay, and so the idea here that we're trying to extend this now to through our understanding of acute hypoxemic respiratory failure in patients with ARDS, we're still looking for this holy grail of where the right place is for extracorporeal support and how it might affect again the management of these kinds of patients in difficult cases, as we'll talk about briefly. I think we might have that solved a little bit, but certainly thinking about on the frontier of other patients with maybe more moderate disease, where might extracorporeal support help us to achieve this idea of an alternative to breathing, and would extracorporeal support facilitating an alternative to breathing actually lead to better outcomes for our patients? That's really the key concept. Okay, so quickly to talk about the current state. So again, in 2025, we have a multitude of ways to connect patients to veno-venous ECMO, which is what we're going to be focusing mainly on today, because again, in the setting of respiratory failure, we mainly need to support patients with veno-venous ECMO rather than alternative strategies. And so it's a nice article from my colleague Lavina Munshi here in Toronto, sort of detailing the 3 sort of primary ways that we think about connecting patients. The first being the internal jugular femoral route, where blood is drained from a large central vein. In panel A, you could see, which is the right femoral vein, sent by centrifugal pump to a membrane lung where oxygen is added and CO2 is removed. That arterialized blood then is pumped into another large central vein, here the right internal jugular vein. And you can see here that basically it's connected in series with the native cardiopulmonary circulation. So here the arterialized blood is pumped into the right heart. This means the heart needs to be functioning. So the right heart is to pump that blood into the pulmonary circulation. That gets into the left heart. The left heart has to be working to pump that into the systemic circulation. And so in this situation, again, it's helping the lungs, but it's not providing any direct hemodynamic support. So you need a functioning heart. These other panels, B and C, depict maybe less common ways of connecting patients to VV-ECMO in 2025. So certainly in panel C, we now have these large bicable dual lumen cannulas. So if you will, maybe a bit like a very large dialysis catheter, where we've combined the drainage and the reinfusion cannulas into one single cannula that here is inserted into a large central vein, here the right internal jugular vein. You can see in the inset that the cross-section of this cannula shows a much larger drainage lumen depicted in blue as compared to the reinfusion lumen, which is depicted in red. And the tip of the cannula sits in the IVC, so you have drainage ports both proximally in the SVC, distally in the IVC, and a reinfusion port in the middle. Typically, when this cannula is placed under fluoroscopy or echocardiographic guidance, is directed at the tricuspid valve, so the reinfused blood has the path of least resistance to get through to the right ventricle and then through to the pulmonary circulation. We typically, in my center, use this kind of configuration in patients that we're looking to bridge to lung transplant, because again, the idea being that almost always we can get these chronic respiratory failure patients unsedated and awake and participating in some form of physical therapy, and freeing the groins from cannulation might be very useful in that situation. I would say in most AHRF or ARDS patients, we don't typically move to cannulating them with this particular configuration. And in the middle, you could see this femoral-femoral approach where both femoral veins are cannulated for VV-ECMO support. This is typically a popular cannulation configuration in certain centers, such as in the Alfred Hospital in Melbourne. Our colleagues there like to use this configuration. It's also quite useful in situations where, for instance, in complex intraoperative settings where you're doing airway surgery or complex thoracic surgery where you're trying to support patients with ECMO, sometimes the femoral approach is useful because the cannulas and support structures are outside the field, the operative field. And so that might be a useful type of supports for this kind of situation as well. Again, for this group, probably don't need to get into too much detail, but again, in 2025 now we have good data suggesting where the use of VV-ECMO in patients with ARDS could be efficacious. And here I've highlighted actually the most recent and more modern randomized controlled trial in the space, which is of course the EOLIA trial led by Alain Combe and colleagues in Paris. And we were fortunate to be a study site for this trial in Toronto. And this, along with the CSER trial, represent the two modern randomized controlled trials trying to answer the question of, is VV-ECMO effective in patients with severe ARDS? As you're likely aware, in the CSER trial, which did show a statistically significant benefit in 6-month survival without disability, which was the primary outcome, there were a lot of challenges with the interpretation of CSER because, again, 25% of patients who were transferred or randomized to the ECMO group never received ECMO. They got better without ECMO. And it was sort of viewed as a trial that was more about transferring patients to an expert center where you could get ECMO that led to the benefit rather than ECMO alone. And so the EOLIA trial was designed to try to answer this question more precisely, if you will. And the idea here was that using expert ECMO centers where transfer was less of an issue was to, again, sort of drill down on the efficacy of VV-ECMO itself in patients with severe ARDS. The trial was designed to enroll 331 patients in an adaptive design. You can see here the Kaplan-Meier curve on the left. The trial was stopped early after 249 patients were enrolled due to futility to show a statistically significant result at a planned interim analysis. And the primary outcome of the trial was 60-day mortality. And so what you could see here is that there was an 11% absolute risk difference in favor of ECMO, but that didn't quite reach statistical significance. And again, the trial was stopped early because simulations at this interim analysis show that even if we progressed to enroll 331 patients, we were unlikely to show a statistically significant difference. So no time today to talk about the wisdom or not wisdom of dichotomizing trial results by the almighty p-value, but almost all the secondary outcomes in this trial were also in favor of ECMO. In fact, there were even less strokes in the ECMO group. In an editorial to our trial written by Jeff Drazen, who's the editor-in-chief of the New England Journal at the time, sort of suggested that this is a almost like a positive negative trial. Like all the results seem to move in the direction of ECMO, although we didn't quite reach statistical significance for the primary outcome. And when the primary outcome doesn't reach statistical significance, then you look for other data to help support this idea. And what you could see on the right is the flurry of activity, if you will, that occurred after the publication of the EOLIA trial to try to sort of shore up our ideas of where the evidence was leading us in the answer to the question of, does VV-ECMO help adult patients with severe ARDS? So what we have is a Bayesian reanalysis that was led by my colleague Ewan Gallagher and the co-PI of the platform of the practical platform trial that again showed across a range of prior beliefs from very skeptical to very enthusiastic that there was an over 89% chance of benefit of ECMO when using data from both the CSER and EOLIA trials. Again, my colleague Lavina Munshi here, in somehow I made it big. Here we go. In a traditional study level meta-analysis showed that when we merge the data together, again, there's a statistically significant benefit for mortality with VV-ECMO. There was an individual patient data meta-analysis led by Alain Combe and Giles Peake, the PIs of the CSER and EOLIA trials that again showed a statistically significant benefit for ECMO. And here's just one of now maybe 5 network meta-analyses. This one was led by one of my graduate students, Hiroko Mioma, that again showed that along with prone positioning, VV-ECMO was a significant benefit to patients with severe ARDS. So in totality, the synthesis of the available data suggested that VV-ECMO was beneficial in these patients. And again, now we've codified these results in international clinical practice guidelines. So when we initially issued them in 2017, we couldn't make any recommendations because only the CSER trial had been completed at that time. But here you could see that in 2023, the ESICM issued a strong recommendation for the use of ECMO in these patients. And similarly, in an update to our ATS guidelines, we also issued a recommendation for the use of ECMO in these patients. So we feel that for severe patients, at least, meeting EOLIA inclusion criteria, the question of VV-ECMO or ECMO use in these patients seems to have been solved, and we feel there's a benefit and that it should be used in this patient population. Things that we're still concerned about and we still need to figure out is that how do we, in terms of patient selection, what's the right deployment? Lots of questions around, when and whom ECMO would be best served is also the question of longer term challenges. So we know from seminal work from my colleague here in Toronto, Margaret Harridge, that clearly that while survival is short-term survival is very important in these patients, even amongst survivors of ARDS or respiratory failure, they leave the ICU with substantial morbidity that could last for up to 5 years, right? They're weak, they don't return to work, they've lost 20% of their lean body mass, they have anxiety, depression, post-traumatic stress disorder, lots of challenges for these patients. There's burden on their caregivers. And maybe some of the things that we're doing in the ICU, the exposures that these patients have in the ICU. So bed rest, sedation, paralysis, developing delirium. These things might have an impact on these longer term outcomes. And so how might ECMO help or hinder some of the outcomes in these patients? That's also very important to know. And we're very, these are sobering results from my colleague Carol Hodgson in Australia, suggesting that there's more work to do on this. And of course, this is part of the reason that Expand ECLS is going to, as I'll mention to you, look specifically at some of these patient populations and interventions. If you focus on panel C, these alluvial plots on panel C here for VV-ECMO, it's interesting because when you think about what we just talked about, when we think about patient selection for ECMO in severe ARDS, typically we're picking younger patients, patients who are living independently, they have very little comorbidity, they don't usually have severe multi-organ failure at the time that they're candidates for VV-ECMO. We're really picking the healthier patients, if you will. But interestingly, when you look at 6-month outcomes in this study by Carol, you could see that, again, the vast majority of patients start off without much disability when they have VV-ECMO. Again, we're typically choosing patients who are healthy and don't have disability, but about 1/3 of patients transition to moderate or severe disability at 6 months. So even amongst this very selected population of patients that we choose for ECMO, a good proportion of them develop moderate to severe disability, even when we select on sort of the relatively healthy subgroup of patients as candidates for VV-ECMO. So is there a way that we can modify either how we're choosing patients or how we're using ECMO to not only affect short-term mortality, but longer-term morbidity? This is something that we're very interested in studying in the Expand ECLS domain. Okay, so the idea then, of course, is that, interestingly, one of the reasons that we think that ECMO is very effective in patients with ARDS is that not only does it fix life-threatening gas exchange problems like hypoxemia and hypercapnia and respiratory acidosis, is that also transferring the work of breathing, if you will, again, back to our idea of the alternative to breathing from the native injured lungs to ECMO, facilitates an important reduction in the intensity of mechanical ventilation that needs to be delivered to the injured lung. So this concept of lung rest. Why make the injured lung work if we can transfer that work to a machine and give the lungs time to heal and that sort of thing? And the data sort of suggests that this concept of reduction in intensity of mechanical ventilation is likely an important component to the benefit that we see in trials like Eolia. And of course, this fits with our concept of the last few decades of ventilator-induced lung injury. We know that obviously as the intensity of mechanical ventilation increases, the risk of ventilator-induced lung injury in these patients increases, and anything to mitigate that risk might lead or translate into clinical benefits for the patient. So another popular idea has been the idea of, can we build systems of extracorporeal support that are actually not as intense as full-out VV-ECMO, but could we use a low-flow device that focuses mainly on CO2 removal and not so much oxygenation? So we might deploy this in less sick patients, and we can use the CO2 removal device then to, again, facilitate this reduction in the intensity of mechanical ventilation. If we reduce things like, airway pressure, tidal volume, respiratory rate, and the idea of reducing the risk of ventilator-induced lung injury, you're going to get more hypercapnia and you're going to get respiratory acidosis. And at some point that will be limiting, despite our concept of permissive hypercapnia in these patients, that'll be limiting in terms of how much you might reduce the intensity of mechanical ventilation. But if we have a device that can remove the CO2 or the consequences of that reduction, then that might facilitate, again, the ability to reduce intensity further. So we have these systems now called ECOR, or extracorporeal CO2 removal devices, that do work at low flow. They're more like, say, CRRT devices with lower flow, maybe in the half liter to liter range, rather than full-blown VV-ECMO that's typically operating at the 3 to 5 liter range. These use smaller catheters, which again are more like dialysis catheters, and they use large cannulas, which we employ in VV-ECMO. And again, in 2025, we have two ways that we might connect these kinds of devices to patients. One is the more popular one, which is a dual lumen cannula that sits in the central vein here, the right IJ, works very much like a dialysis catheter and runs at low flows. Some older systems actually are pumpless. We connect them in an arterial venous routes. The patient's native cardiac output pumps the blood from the arterial system through a very low resistance membrane lung that removes the CO2, and that blood then is pumped back into the venous system. These systems, again, are now still available, but probably used less than the veno-venous systems that we have available on the market. And again, this sort of fits the concept, and this is important for the rationale, the design of the trials in EXPAND ECLS, is this idea that a good proportion of the benefit we think of extracorporeal support in these patients is this ability to facilitate a reduction in the intensity of mechanical ventilation and mitigate VILI. And again, when you look at the Eolia trial, which I showed you previously, if you dig into the supplement, what you'll see is that, interestingly, when you look at the subgroups, the patients who are the most hypoxemic, so here in Eolia, we dichotomize patients at the median PF ratio. What you can see here is that patients who are very hypoxemic, so PF ratio less than 66, there was actually really no difference in mortality between these groups for ECMO versus control. But when you look at the less hypoxemic patients, actually there was a dramatic difference in mortality in favor of ECMO, nearly a 20% reduction in mortality for patients in the less hypoxemic group. So again, this goes against the idea that we typically think of is that VV-ECMO is saving or rescuing patients who are having life-threatening hypoxemia. There certainly is a small proportion of patients there, but we see that, and at least in the Eolia, the effect seems to be more concentrated in patients who are less hypoxemic. And then interestingly, with this idea that we might be modulating VILI risk, is this idea that when you look at baseline driving pressure as a measure of intensity of mechanical ventilation in these patients, which again, you could see is that in patients who had a baseline driving pressure less than 16 centimeters of water, really no big difference in mortality between ECMO and control groups. But when you look at the patients who had high driving pressure, so arguably those at higher risk of ventilator-induced lung injury, again, you see the more dramatic difference in mortality in favor of the ECMO group in patients where we believe that they had high driving pressure at baseline, higher risk of ventilator-induced lung injury, and that perhaps in these patients, by instituting ECMO, we had the ability to reduce intensity mechanical ventilation. Therefore, we see this difference in mortality. Of course, these are subgroup analyses. You could see the p-values for interactions. These are hypothesis generating, but sort of fits the rationale for what we think one of the main mechanisms by which ECMO where extracorporeal support exerts its benefits in patients with AHRF or ARDS. So we tried to test this hypothesis, obviously, in a trial, which is always a good idea. And this is work from the REST trial led by James McNamee and Danny McCauley in the United Kingdom. This had originally set out to be the largest clinical trial of mechanical ventilation or extracorporeal support ever conducted. They originally wanted to enroll up to 1,100 patients, randomized to either a strategy of CO2 removal to facilitate a reduction in tidal volume from 6 mils per kilo to 4 mils per kilo predicted body weight versus best conventional mechanical ventilation alone. Again, if you focus on the Kaplan-Meier curve here on the right, you can see that the trial was stopped early after 405 patients were enrolled, both again for futility at an interim analysis and also for a signal towards harm. So when you look at the mortality curves here, you can see that in orange, I guess, the CO2 removal group, not only was it not better than mechanical ventilation, but mortality was higher in the CO2 removal group. Okay, here you can see the numerical figures. So it's about 41.5% in the CO2 removal group and about 39.5% in the ventilation group. That was not statistically significant, but certainly the mortality was moving in the wrong direction. Other outcomes also moved in the wrong direction. So there were less ventilator-free days in the CO2 removal group. And importantly, there were significantly more intracranial hemorrhages in the CO2 removal group, okay, which was the signal that worried investigators and led, both along with futility, to stop the trial early. And this is despite looking on the left, them reaching their physiological target. So by day 2, the CO2 removal group did indeed reach an average tidal volume of about 4 mils per kilo predicted body weight, and that led to a concomitant reduction in driving pressure of about 2 centimeters of water. So very small or modest change in driving pressure, but clearly whatever benefits were accrued from this reduction in intensity of mechanical ventilation, unfortunately, were offset by complications related to the device. Okay, so this at least led again in the ESICM guidelines in 2023 to suggest that at present, CO2 removal devices shouldn't be routinely employed in patients with AHRF or ARDS, and they should be sort of kept in the realm of clinical trial investigation. And again, part of this is this idea that we've discovered that not all CO2 devices are made the same, if you will. Different devices have different characteristics. So again, the REST trial doesn't paint a broad stroke to tell us that the idea or the concept of CO2 removal is bad. It just tells us, of course, that the device tested and the protocol evaluated in the trial may be not the right way to go. And we have some data, this is from the Supernova study that we conducted a number of years ago on the auspices of the European Society of Intensive Care Medicine, that told us that amongst the devices that are available, there are some devices that are less efficient, have lower CO2 extraction, and others that are more efficient and have higher CO2 extraction. And again, the idea that perhaps focusing on higher extraction devices could lead to more patients reaching this goal of a reduction in the intensity of mechanical ventilation with fewer adverse events. And so again, remember that in REST, adverse events were important, intracranial hemorrhages. So maybe we need to, in future studies, think about what the right CO2 removal or extracorporeal support strategy is. It's not a one-size-fits-all situation. And again, it's important to investigate these in a clinical trial because we now know from multiple other studies, many of them observational, here's a few listed in this study that was led again by Danny McCauley's group in the UK, that there's a ton of complications related to these sort of low flow CO2 devices, limb ischemia, bleeding, catheter displacement, thrombocytopenia, all these sorts of situations. So again, if we're going to pursue a strategy of extracorporeal support to facilitate a reduction in mechanical ventilation intensity, we need to pick the right device, the right strategy, because of course, any benefits that could be accrued from this intervention are going to be offset by the risks or complications of the device and strategy. So we want to have the right, obviously, intervention and the right machine or strategy to facilitate that, to have the optimal net, we hope, benefit for the patient. So this is all the thinking and going into the design of the studies I'm going to describe to you today. And again, I would say part of the reason you'll hear is why we chose the strategy that we did is this idea that at least at present, there's not a lot of available low flow devices on the market that lead probably to a reasonable adverse event profile, at least at present. We have lots that are in the pipeline from companies that are under investigation. And so we're very hopeful that this is a changing idea. But this is nice work from Christian Karagianidis and Cologne, showing that, again, part of the challenge is that we know that at high pump speed, these devices can induce shear stress, trauma on the blood, hemolysis, platelet activation, and other challenges, but it also can be caused at low blood flow. Actually, there's increased dwell time for platelets and blood in the pump that also leads to activation, that can also lead to hemolysis and that sort of thing. So again, at the extremes of pump speed in these sorts of devices, we know there could be problems. So again, the sweet spot is to operate these devices at moderate sort of pump speeds. And until we have new devices that, again, could sort of present a better adverse event profile, maybe using sort of ECMO devices that we have currently on the market at moderate flows is the way to go. And you'll see that's what influenced our ideas around how we're using extracorporeal support in the studies in practical. So this is the idea of what is next. And so the idea here again is that, so we have some studies like REST that focused on low flow CO2 removal. And again, at the present time, that doesn't seem with available devices to be a viable strategy, at least at the moment. We obviously have high flow ECMO studies like CSER and Eolia. That's more in the situation where we need oxygenation in patients with very severe gas exchange disturbances. It's a small proportion of patients who have very severe ARDS who qualify for that. But then we have this whole group in the middle, right, of moderate ARDS patients. They typically make up 50% of ARDS patients, and maybe using a sort of, whatever you want to call it, a high flow CO2 removal or a low flow or mid flow ECMO strategy, where we, again, we're not so much focused on oxygenation, but we are maybe focused on CO2 removal, reducing the intensity of mechanical ventilation, reducing VILI risk. Hopefully that translates into a mortality benefit. So that might be the patient group that we want to focus on in these studies. And again, in a certain population of patients, maybe because they're less hypoxemic, this transfer of work from the injured native lung to the ECMO machine might also facilitate the ability to reduce sedation, reduce paralysis, get these patients awake, maybe off the ventilator and up and moving. And that might also, again, then shift our idea from just focusing on short-term mortality, strict lung protection, to this idea of a more holistic approach to the patient, which could help with morbidity. And that's what we're going to talk about for EXPAND ECLS. So for the first trial I'm going to talk about is like based on the rationale that's been presented, the idea that we might promote better lung protection by using an extracorporeal strategy in some of these patients to facilitate a more dramatic reduction in the intensity of mechanical ventilation, however you want to manage it, is this idea that probably we could achieve these goals again outside of severe ARDS patients where Eolia and CSER have already shown us there's a benefit. But in this more moderate group, so PF ratio, say 80 up to 150, there does still seem to be a benefit of VV-ECMO in these patients. So this is secondary analysis from a target trial emulation that we conducted on global COVID-19 critical care consortium data, published a few years ago, led by Martin Erner, one of my colleagues and former graduate students. What we could see here is that when we emulated a trial in COVID-19 patients who were with severe ARDS who required ECMO, that indeed, when you looked at like Eolia type thresholds, a PF ratio less than 80, there was a 7% risk difference in favor of ECMO, so very close to the Eolia trial. But indeed, if you looked at alternative thresholds, so if a PF ratio even up to 150, there still seemed to be a benefit in favor of ECMO. So even amongst less hypoxemic patients, as measured by PF ratio, there seemed to be a benefit of VV-ECMO on mortality in these patients. So some rationale to suggest that we could extend the use of VV-ECMO in these patients. And again, the mechanism might be the ability to reduce intensity of mechanical ventilation in these patients. And we know that even when we have religious adherence to low tidal volume ventilation or lung protection in these patients, that still a substantial proportion of them could have tidal hyperinflation on a breath-to-breath basis. This is nice work by Tarini and under Marco Raineri's group when he was still in Torino, showing using CT scanning that indeed, that even when we're giving what we think is the best lung protection, that there's still going to be a proportion of patients who have VILI risk on a breath-to-breath basis. So again, facilitating a further reduction in these patients in intensity of mechanical ventilation could be important. And now in 2025, we also think that maybe alternative targets, rather than focusing specifically on tidal volume reduction or plateau pressure reduction, for instance, that maybe focusing on things like driving pressure, which seems to be the most significantly associated variable with mortality in these patients. So maybe focusing on reducing driving pressure might be the way to go. And we've plugged that into the rationale for our study. And of course, again, we don't yet have a trial showing that limiting driving pressure leads to a benefit. Many of you are participating in the DRIVE trial being led by Ewan Gallagher, Neil Ferguson, and Serena Sahathia to hopefully demonstrate that through a randomized trial that limiting driving pressure will lead to a durable benefit in mortality and other outcomes in patients. But again, when we don't have a randomized trial, we do the next best thing, which is to emulate a trial using existing data. So again, this is work from Martin Erner and our group using data that we have in Toronto on over 12,000 mechanically ventilated patients, showing that when you add driving pressure reduction on top of already lung protective ventilation, there is maybe an additional nearly 2% reduction in mortality amongst these patients. So there does seem to be a rationale for focusing on driving pressure, even when you're already delivering lung protective ventilation. And again, of course, the DRIVE trial will sort of tell us what the results of this kind of a strategy is in a clinical trial, but at least there's some rationale here to focus on driving pressure. And again, we can extend that a bit further, because not only can the use of extracorporeal support help us to reduce the intensity of mechanical ventilation through the pressure that's delivered to the system, but because it's removing CO2, we can also reduce other parameters that we think are related to the development of ventilator-induced lung injury, including parameters like respiratory rate. So we could facilitate, through the use of extracorporeal support, not only a reduction in driving pressure, but also respiratory rate. And of course, this figures into the idea, pioneering idea, again, by Luciano Gattinoni, about mechanical power. If you transform the equation of motion to ventilator parameters, you could see that this is sort of the power or energy delivered to the respiratory system that the injured lung has to dissipate. And we think that's also represents an important mechanism or understanding of how villi develops in the injured lung. And so again, the idea is that you have components that distend the lung, move the gas, and keep it open. But we're focused, again, driving pressure reduction is as part of the distend the lung portion, but we can also perhaps reduce villi risk by respiratory rate in the system. And again, we have data from our registry of nearly 10,000 patients showing that there is a very clear association between higher mechanical power and mortality. So the idea here, again, that if a reduction in mechanical power may facilitate improved outcomes in these patients. So the sum total of that rationale, and I'll get at the end of the talk into the details about the trial, is the rationale for the ultimate pilot trial that Neil Ferguson and I are leading as a part of the Practical platform with a large team across Canada. Some of them you can see named here, with the idea of that can moderate flow ECMO facilitate more ultra lung protective ventilation, with a focus again on reducing driving pressure and then reducing respiratory rate in these patients compared to best conventional mechanical ventilation in this group of moderate ARDS patients. And this is a pilot study that forms the first part of the EXPAND ECLS combo, if you will. And so again, this is the sort of traditional thinking that's sort of the son or the follow-on from trials like CSER and Eolia, where the focus is on lung protection and how we might enhance lung protection through the addition of an extracorporeal support device. But the interesting thing from my point of view, or maybe the more interesting thing, is how we might extend this idea even further. And this is, again, the idea of shifting our focus from short-term mortality, strict lung protection, to thinking about more holistically about the patient as a whole and how we might affect morbidity in these situations. This is an amazing, I think, commentary that was written by Nate Brummel a number of years ago, almost 10 years ago now, in the Blue Journal, called Willie Sutton and the Future of Acute Respiratory Distress Research. And the interesting thing that Nate wants to point out here is that as pulmonologists or critical care specialists and thinking about ARDS, is that we've always thought of ARDS as a pulmonary syndrome. And that makes sense. These patients show up with hypoxemic respiratory failure, they're hypercapnic, the lung is white on x-ray, we need to ventilate them. So all the strategies have been focused on respiratory failure, focused on the lungs, focused on the chest, focused on the problem that it presents itself. And our interventions like mechanical ventilation, adjuncts, prone positioning, all these things have been focused on the lung because we think ARDS is a lung problem. But of course, now we know that the major driver of mortality and morbidity in these patients is not the lung. In fact, it's a systemic syndrome, right? We know these patients, again, are leaving with multi-system challenges, both in the short term and the long term. And ARDS is more of a systemic syndrome than it is of a strict pulmonary syndrome. So maybe our interventions also need to think more holistically about the whole rather than just focusing on the lungs. And of course, it starts as a lung problem, but then affects the brain, the heart, the kidneys, the muscles, the nerves, and all these sorts of things. And so when we need to think about maybe is broadening our concept of the management of ARDS or AHRF patients beyond the lungs, because although it starts there, it becomes a whole body problem for our patients. And if we're going to improve clinical outcomes, we need to think about it in that way. And again, I show this example, I have permission to show the patient photos that I have, is that when we're thinking about strict lung protection, then we do things that maybe are very good for the lungs, but maybe not so good for the patient, the whole patient, if you will. So here's a patient of ours that had blastomycosis, which is a fungal infection endemic in parts of Northern Ontario, who's supported with VV-ECMO, who still had refractory hypoxemia, is deeply sedated and paralyzed. And then because he was having ongoing challenges with both ECMO and mechanical ventilatory support, we went on to prone this patient. This is a number of years ago, actually before the pandemic. And so what we could see here is that when you're focused on a strategy, this is just one example of strict lung protection, you got deep sedation, paralysis, bed rest, okay? Low levels of mechanical ventilation and this sort of thing. So the lung is protected here, but of course now the patient's bedridden. They're having probably disuse atrophy. They're deeply sedated. They're paralyzed. And some of these things are going to have, as you might imagine, adverse events on their neurocognitive outcomes, their neuromuscular outcomes. There may be the development of neuropsychiatric morbidity, like, again, depression, anxiety, post-traumatic stress disorder. So while we're protecting the lungs and the focus there, we might be having adverse outcomes on the rest of their them if they're going to survive their ICU stay. And so the idea, of course, is that maybe we need to shift the focus and use extracorporeal support devices to facilitate the awake, calm, cooperative, and mobile ICU patient. So here's another dramatic example, if you will, of a young patient. This is a bit of a cheat because he's not so much having AHRF, but this patient had a cystic fibrosis and had a lung transplant, had chronic lung allograft dysfunction, and was here for a retransplantation. He showed up to the emergency department with a CO2 above 150, was obtunded, was intubated. You could see he's intubated here. And by morning, after we had connected him to a CO2 removal device, he was awake with a relatively normal blood gas. And you could see he's displaying the results of the machine. That facilitated extubation in the morning for this gentleman rather quickly. And that afternoon, he was able to get up and move around while on the extracorporeal support device. So the idea here is, can we shift the paradigm and think about ways that extracorporeal support can not only maybe protect the lung, but protect the whole body and affect morbidity. So again, this idea of a paradigm shift away from short-term mortality and strict lung protection to, could we use extracorporeal support in these more moderate ARDS or AHR patients to reduce the need for sedation, paralysis, immobility, and again, facilitate the awake, calm, cooperative, mobile patient. And at least as a proof of concept, this seems to be possible. So here's a case series from Rush in Chicago during COVID, where they did just that. They put patients with severe COVID-19, so those were associated respiratory failure. They cannulated them with a venopulmonary route of ECMO support. So there might be something with the configuration that they chose. But the idea here was not so much to focus on strict lung protection, what was to get patients desedated, off the ventilator if possible, and then up and moving as quickly as possible. And what you could see on the left, I'm not going to get into the details, is that they have like the timelines. And indeed, they got the vast majority of their patients extubated, some off the ventilator through tracheostomy. They were awake, obviously, from that, and they were able to get up and move during their ICU stay and before ICU discharge in a substantial proportion of their patients. Interestingly, this was all associated with very low mortality in the 20% range, which is much lower than many reports of ECMO-supported COVID-19 patients. So again, this is a case series, observational data, so we can't make any firm causal inferences from these data, but certainly as a proof of concept suggests that in the right patients, ECMO could facilitate this strategy of early awakening, early liberation from mechanical ventilation, and early mobility. And again, we might imagine that it would be easier to do that in patients with more moderate ARDS or HRF than it would be in the most severe patients who are very hypoxemic. There's going to be trade-offs to this kind of strategy, of course, and the idea is, again, we're shifting our focus away from short-term mortality to thinking about morbidity. You know, implicit in this is the idea that maybe ECMO complications in 2025 are less than mechanical ventilation complications. So the idea that, again, that maybe now the trade-off is more in favor of leaving patients on ECMO and getting them off mechanical ventilation, and that may be helpful. And again, moving away from strict lung protection to this idea that we might affect better physical and mental health complications in these patients. We need to test this in a randomized trial because, again, there are important adverse events associated with this kind of a strategy. So although this trial, the TEAM study, again, led by Carol Hodgson in Australia, isn't specifically associated to ECMO patients, but the idea that early mobilization in these patients, and especially you might imagine in our sicker patients, actually, it didn't lead to any significant benefits in days alive and out of hospital at 180 days. But importantly, in the TEAM study, they showed that there were significantly more adverse events due to mobilization. Now, many of these were not serious adverse events. And again, some of this is expected. if you leave a patient in bed and don't move them, you're not going to get adverse events like, say, desaturation with exertion. You're not going to get accidental NG tube removal or accidental extubation or line removal or kinking or that sort of thing. So some adverse events are going to be expected with increased mobilization, but of course the number of serious adverse events needs to be adjudicated. And again, in ECMO patients specifically, we need to test to see what the trade-off with getting patients up and moving more would be as compared to a strategy where they're not moving as much. And again, since COVID, there's been a lot of discussion that if we get these patients unsedated, awake, maybe off the ventilator, that more exuberant spontaneous breathing could occur in these patients. There could be a risk for this so-called patient self-inflicted lung injury, where sometimes we think that mechanical ventilation could interrupt the risk for PCILI or patient self-inflicted lung injury. Again, we might need to test a strategy where we're using the extracorporeal support to try to modulate the risk for PCILI in these patients. And again, with the idea that we might be able to, in these less severe patients, improve their gas exchange, as well as interrupt increased respiratory drive through modulating CO2 using sweep gas flow in some of these patients. So all of this together has come up with this idea of proactive, which is the second part of the expand ECLS domain. And here we're trying to, again, focus not just on strict lung protection, but really try to focus on putting these patients onto ECMO with moderate ARDS to facilitate early awakening, early liberation, and early mobility in these patients, and replicate, if you will, the results that we saw in that JAMA surgery report from Rush University. We're doing this in conjunction with colleagues in Australia. Aidan Burrell is one of our co-principal investigators, as well as centers in Europe, including at the Charité Hospital, where they've already done a number of these patients in a pilot study showing the feasibility of such a strategy. So this is the second part of the expand ECLS domain. I'm just cognizant of the time. I might just skip ahead to just a summary of the study and then maybe let you answer any questions you might have. So again, both of these interventions at the moment are pilot randomized control trials on the practical platform, so maybe different than some of the other studies that you've heard about in other webinars. So at the moment, so it's a relatively small sample size. Expand ECLS, because we're focused on the same population of patients. We're focused on moderate HRF patients with a PF ratio of 80 to 150, PF 80 to 150, who are less than 48 hours from the diagnosis of AHRF. And again, because they're both pilot studies focused on the same intervention, we actually created Expand ECLS by merging these, what were two separate trials previously, into a single trial to facilitate and make more efficient the conduct of the study. So we can see here is now the total sample size is 100. We're having randomization, unequal randomization with a preference towards the intervention group. So it's a 1 to 2 to 2 randomization in centers that are conducting Expand ECLS. So 40 patients for the ultimate intervention, 40 patients for the proactive group, and 20 patients in the IMV control group, which is similar to the control group in, again, the DRIVE study as an example. And because these are pilot studies, the main outcomes of the study are feasibility, safety and feasibility. So how feasible is it to recruit? How much protocol adherence is there? How limited are the crossovers? We have some, again, clinical metrics that we'll collect as secondary outcomes in both studies. But again, these are pilot feasibility and safety studies. So the first point was to demonstrate safety and feasibility of these two strategies in moderate ARDS patients. Again, a patient group that we're not typically employing ECMO in. And of course, following on the demonstration of safety and feasibility, we'll make a decision about transitioning one or both of these protocols into a larger phase 3 efficacy study in the future. So I think I'm going to stop there. And the other slides was just sort of outlining some of the stuff that we already talked about these specific patient groups, and give you a chance to ask me any questions or provide any comments or feedback that you might have. But really to say that, again, I hope I've convinced you that at least for severe ARDS, we have maybe a more clear picture now that VV-ECMO is indicated in these patients as per the Caesar Eolia trial. So it's not a question of if anymore, but when and in whom. And other research is working on refining the ideas around timing, patient selection, patient criteria, and that sort of thing. We're really focused on this idea of, could there be a role for extracorporeal support in less severe HRF and ARDS, so-called moderate group? And again, that further reductions in ventilator-induced lung injury here might improve outcomes. And here we're focusing more on novel targets, such as driving pressure and mechanical power. And then we're very interested in this idea of maybe shifting the paradigm towards morbidity rather than a strict focus on lung protection and mortality. And can we use ECMO in a proactive intervention group to facilitate the awake, calm, cooperative, and mobile patient? And we're looking forward to presenting the results of these pilot studies when completed to the group in the coming coming time. So with that, I'm going to finish and let you ask any questions that you might have. Thanks so much for your attention. Any questions or comments, feelings?
Well, maybe I'll ask the first question. Thank you,
Sure.
Dr. Fan. I'm just wondering, when it comes to the setup of the Expand ECLS domain, what are some of the challenges? And as you have the domain executed now, what are some of the challenges that you face? Do you mind sharing?
Yeah, thanks, Kathy. So I would say one of the main challenges, interestingly, has been we have an enthusiastic group of co-investigators across Canada. So these pilot studies are being conducted across Canada, just as a pilot study. So there are really no international centers involved. But it's been interesting, like in sort of having this discussion about, first these domains separately, but then now as a combined intervention amongst our co-investigators across the country, there's been variable uptake on the idea of deploying extracorporeal support in patients with more moderate disease. So there's been a bit of a challenge that despite the fact that we don't know the answer, which is why we need to study it, just like when we didn't know the answer in severe ARDS, we need to deploy ECMO, and there's clearly a risk of ECMO as an intervention. There's been variable comfort, if you will, with the idea of now deploying ECMO, which again is an invasive, it's risky, it's a costly intervention, resource intensive, in now patients with more moderate ARDS, that it's unclear in some centers that there's enough equipoise to undertake that. So we've actually spent quite a bit of time discussing with our colleagues, having meetings with their intensivist group, their surgical group, their research group, to discuss the rationale as we had today and design and why we're pursuing a strategy of deploying extracorporeal support in less severe patients to answer this, what we think is an important question of, is there a role for this to improve outcomes in the group? But that's been, I would say, one of the bigger challenges is that, clearly these patients are less sick, so they're at a lower risk of mortality, but there is going to be some fixed risks associated with the deployment of the device and the intervention. And so that was a very interesting, it's been an interesting and ongoing discussion around equipoise for the deployment of this intervention in these less severe patients.
Thank you.
You're welcome. Glauco?
Hi, Eddy. Thank you for the amazing talk. I wanted to ask you, do you think that regional anticoagulation could be a possible solution for the use of extracorporeal CO2 removal? Thank you.
Yeah, it's a great question, Glauco. I mean, certainly this is an intense area of investigation, not in the Expand ECLS domain, but if you will, the main concern for many people who use ECMO or use CO2 removal or use extracorporeal support is the bleeding complications. These are the ones, they're probably just as common as thrombotic complications, but it's very clear from the data that bleeding complications are more significantly associated with adverse events like death, right? And of course, intracranial hemorrhage being a very feared complication. So the more that we can reduce bleeding risk and the need for anticoagulation in these systems, we think would reduce this sort of risk associated with ECLS, right? And so whatever the benefit that you accrue from being attached to one of these systems, if we can reduce the risk, the net benefit for the patient would presumably increase. So, and regional anticoagulation is a great example of an idea that's being pursued by many device manufacturers, especially in lower flow devices, right? The challenge of regional anticoagulation on a high flow VV-ECMO device is that it'd be too difficult and too logistically challenging when the flow is 5 liters to provide enough, and the risk of overdoing it or especially overshooting in regional anticoagulation when the flow is very high is challenging. But in a low flow device that's very much like CRRT, that could be possible. So there are groups that are pursuing this as a strategy. There's no, at least maybe I'll restrict my comments to the Canadian market. At the moment, there is no device available that's Health Canada approved on the Canadian market that could provide this kind of approach, but certainly there are now increasingly companies that have CO2 removal devices related to a CRRT platform that then could probably have some kind of regional anticoagulation system available with it. But even, I would say, again, pushing the paradigm further, Glauco, to your point, is that we're now sort of recognizing even in the full-out VV-ECMO world, and again, this is part of the rationale for why we decided to go with mid-flow or moderate flow ECMO rather than low flow or higher flow CO2 removal, is that there's some data now suggesting that when you're running ECMO at sort of moderate to high flow, you may not need any anticoagulation at all. So we can very much reduce the risk of bleeding by not providing heparin at all. So there's a ton of case reports and case series now from multiple centers around the world showing that for VV-ECMO, they're actually using just DVT prophylaxis or this sort of thing, or some heparin at cannulation, and that's not led to much in the way of problems. And both ourselves, here a study that's being led by Manuel Tismanetsky and one of our former fellows, Damien Rattano, who's returned to Geneva, that's looking at a small pilot randomized trial of not giving any anticoagulation in VV-ECMO versus standard to see if that's safe and feasible, and a study that was recently published out of Vanderbilt by Whitney Gannon that's also looking at the same thing, and will transition to a larger clinical trial. We're trying to harmonize our efforts there. But again, what's tantalizing about this idea of using maybe moderate flow ECMO in this situation rather than low flow CO2 removal until we get a regional anticoagulation option is that maybe we don't need much anticoagulation at all. So if we eventually have a strategy like you described, I think that could be very interesting. At the moment, unfortunately, we don't. But maybe one of the other advantages of using moderate flow devices is that maybe we don't need very much anticoagulation at all.
Amazing. Thank you so much, Eddy.
Yeah, you're welcome. Well, I don't know. Either I've been very clear, which is probably not likely, or I've been too confusing to generate much in the way of discussion.
Not at all. I think your presentation was really clear. Thank you so much, Dr. Fan. If there are no further questions, maybe we'll call it an end to the presentation. And thanks, everyone. Enjoy the rest of your day. Thank you.
Thanks, everyone.
Bye.